Hi everyone. This is an honor for me to make a presentation the last time. You know, it is often the princess and prince are coming the last. So, yeah, my name is Sukyong Seo. The paper performance in Korean hospital nursing is also co-authored by my colleague Bo-hyun Park, who teaches in Cheongju University in Seoul, in South Korea. Yeah, some of them are, you know, used to the guy who is expert in healthcare quality, Abu Dhabi's Donabedian. I also, as he said, I also like your attention move from, you know, the interaction of one patient and practitioner pair to the provision of care by groups of practitioner to entire population to talk about quality of care. So then we have to think about a number of attributes of care become much of more prominent determinants of the quality of care, which includes structure, process, and outcome. So I would like to talk about today the structure, which is mainly about the story nurse-to-patient ratio. Yeah, the paper performance, the rationale behind paper performance in healthcare is that if compensation, in other words, payments method, is directly linked to the quality of care, providers will shift their effort toward quality improvements. So People P has been adopted in healthcare as a means to alter financial incentives of providers. And People P also has to be well aligned to providers' main financial incentives, such as fee for services and DRGs, something like that. Then we can see their successful achievement in there. So the introduction, the number of active nurses per 100 acute beds was about 4.5 in Korean hospitals in late 1990s, which is quite low comparable with Western standards. There is compelling evidence that nurse staffing directly influences quality of care. So rewarding hospital according to the level of staffing may be an effective way to increase hospital investment in nursing resources. However, as you can guess, raising staffing levels requires substantial investment. So the bonus linked to people fee, which is usually very small, are often too small to cover the labor cost many hospitals require to increase their investment. In 1999, the social insurance in South Korea, National Health Insurance Services, reformed the hospital payment method to promote acute hospital with incentives based on their level of staffing. In 2007, they added disincentives whereby hospitals failing to reach a threshold level had to pay penalties. So a 10-year experience in South Korean hospitals provide a testable cases to examine the effectiveness of finance incentives to increase nursing resources. I wanted to briefly overview healthcare system in Korea, but I feel pressure to, to make my presentation very short. So, yeah, let me try to make this short. Actually, Korea's social health insurance established since 1977, which have been expanded from very limited population to people who work business with fewer employees and self-employed population. So mostly subsidized by government, and the insurance subsidies as a share of total general government expenditure is about 4%. So household premiums, actually an individual has to pay to get care are subsidized by employers and government. But still, consumers have to pay some out-of-pocket money when they visit a doctor. It's about 20 to 55% of the total charge of Medicare, which is not covered by social insurance. So medical providers, including hospital doctors, compensated on based on the fee-for-services basis. A government agency, Committee for Financial Management, set the medical fee schedule and defined the scope of the care covered by government. And they have kept the fee schedule very low because we wanted to cover as many as patients in South Korea. And the last, HIRA, an independent agency, HIRA, the Health Insurance Review and Assessment Services are authoritative to make strategic purchasing, and they have reviewed provider payment scheme and fee schedule, and auditing insurance claim, and assessing quality of care in South Korea. Yeah, this is a diagram how the monies come from National Health Insurance Corporation to the medical care provider. The HIRA is here. This is a auditing and monitoring agency to see whether their claims are correct and whether their payments are correct. So Korean, here is the building blocks of Korean P4P in hospital care nursing, which is composed of a monitoring system, price setting, and an adjustment system. Monitoring system collects data on each hospital's nurse staffing on a quarterly basis, and they assess their staffing level, and then they pay for the quarterly nursing fee, which is called as the nursing administration fee. So nursing administration fee separates the revenue category of nursing care from the daily room and board charge. You know, the nursing fee was originally included in the daily room and board charge, which was hidden, so nobody knows how, knows they have to pay for nurses or not. But the reform, the P4P separates the category out of daily room and board charge. So the nursing fee based on a per bed ratio is not accounting for nursing intensity. They just calculate number of patients divided by number of beds. The second is price setting. The nursing P4P in Korea sets up 6 grades. So hospitals are paid 100% of the nursing fee by NHIS when complying with minimum requirement. Yeah, they are assigned as grade 6. So as the hospital advances into the upper grade, the capital benefit that the hospital would gain increase by 40% of the base rate. So at the highest level, the grade 1, a hospital is paid 300 of the base nursing fee. The third is actual payment adjusting factor. As you know, the labor cost is different depending on the region, whether a hospital is located in the metropolitan area or rural area. So they have some adjustment factor in their system. So they group hospital into a couple of classification, and they put some more money added to the base payment. Yeah, so this is how the grade system looks like. So purpose of this study is to, excuse me, how many minutes do I have? 10 minutes? Okay, yeah. So the purpose of this study is to examine whether the payment incentive leads hospital to increase their nurse staffing, and to examine whether the response to the nursing incentive has been consistent across hospitals with various financial status. And last, I wanted to examine whether the resulting staffing changes improved nurses' working condition or not. So I collected data from various sources, like annual financial report of hospitals from 1996 to 2005. We also performed a nationwide survey of hospital RNs. Measures. As a variable, we put nursing payment reform, so defined as pre-policy year as 1996 and 1999, intervention year 1999, and post-policy year of 3 years. So nurse staffing level were measured from grade 1 to grade 6. So, and we also asked nurses whether your hospital have improved their nursing grade since 2005. So we are, for the measurable nurses' work conditions, we used three separated measures, including job satisfaction, burnout, and intervention to leave. For the measurable characteristics of nurses, we included age, marital status, years of nurse experience, position, etc. And as a hospital characteristics, we used hospital type, size, location, ownership, etc. to control for the effect, effect related to the decision making regarding nurse staffing. So statistical analysis, first we analyze the trend of nurse staffing by comparing data from before the policy versus after the policy. We next examine the fact, we actually run the regression model to see what factors affected the changes in nurse staffing. And last, we used multi-level logistic regression analysis to examine whether hospital nurses had perceived improvements in their working condition after the payment reform. This is descriptive statistics. And the next, this is time series result of the nursing. You know that 1999 was the policy year. So the blue line is the changes in nurse staffing. The green line indicate the changes in number of doctors, which I want to be, compare this with this. So you can see that, the object trend of increasing in nurse staffing after 1999. For general hospital, general hospitals are mostly large, and they have surgeries and big hospitals, and the hospitals are mostly mid and small size and located in a rural area, something like that. So they also have experienced some increases after the the policy reform, but as you can see there's some decreasing trend after 2005. So we suspect that the policy sustained about 6 to 7 years, then their effect was gone. The next, the estimate of the effect of P4 fee in nursing payment on nurse staffing in Korean hospital. The dependent variable was the log of number of RNs. So as you can see, referring to hospital, general hospitals has a positive and significantly coefficient like 0.442. And to see, the effect of policy, you can see the positive coefficient after 1996. They are all statistically significant. Their p-values are less than 0.001. In this part, I wanted to show you that among hospitals, not the general hospital, whether they have improved their staffing levels. So I put the interaction terms like hospital times policy. So as you can see, no significant relationship. Here we see the negative coefficient significance with the statistical significance in intervention term with 3, which means that among hospitals, they didn't see no improvement among the improvement in their staffing after another reform. Next, this is for the the survey data. So we have here is the descriptive statistics. Yeah. So I asked the RNs whether your job satisfaction has been increased after the reform. Yeah. Based on their result, I got that their satisfaction levels have not changed. Okay. Yeah, their satisfaction and burnout level and intention to leave have not changed a lot. Comparing with no change group and advanced by 1 grade hospital, among the hospitals advanced by 2 or more grade. The next, this is the result of the multi-level regression models. So all regression models include nurse demographics and hospital and market characteristics. So as you can see, the job satisfaction, the OR of the job satisfaction is less than 1, which means they didn't see any satisfaction after the exam, and so also we didn't see no. The less than 1, the value is less than 1 here. So conclusion, to examine a decade of experience in P4P in Korean hospital, this study shows that the approach is somewhat effective for the general hospital, but it's less effective to the hospital which mostly, lack nursing resources and financial resources. So I will find this inform policymakers in other countries that a policy to incentivize nurse staffing using P4P can be more effective by considering those hospitals in poor financial shape, general hospital in our cases. So policy implication. Linking institutional level nurse staffing to payment is effective in improving nurse staffing in hospital sector. So this approach could be edited to already existing staffing regulations such as minimum nurse to patient ratio or patient classification system. So to be more effective, careful consideration for hospitals in poor financial shape are required when designing and implementing this approach. Surprisingly, nurse outcomes such as job dissatisfaction, burnout, intention to leave were not significantly improved while overall staffing increased. So investment to improve nurse work condition is required to increase staffing level. Thank you for listening to my presentation.